What's up, FRT community? Teresa Grady has a question for us. She wants to know about anticoagulants and what their effect on the heart is. And so, then kind of step into the realm of, we could call more of a hemodynamics conversation, kind of away from traditional respiratory therapy scope. But this is also good stuff to know. So I always love when we get questions that kind of step just one step kind of outside of our exact domain, because it shows that people are wanting to be better than just, oh, I'm a ventilator specialist. No, you're a total cardiopulmonary specialist, and that's important. So I appreciate you, Teresa Grady, for this message. Hope everybody had a great Thanksgiving. As you can see, my kids left you guys a message back here on the board. They want me to tell all you guys Merry Christmas. So we hope everybody's getting into the holiday spirit. Now, when we talk about anticoagulants, okay, here's the thing. When you talk about their effect on the heart, you kind of need to understand that, first of all, anticoagulants are oftentimes referred to as blood thinners, but you need to understand that they don't actually thin the blood. They don't change the consistency of the blood. What they do is prevent clotting from happening. And so patients receiving anticoagulants are those patients that are at increased risk for clotting. We know that when clots travel to pulmonary circulation, to the coronary arteries, or even to the cerebral circulation, that bad things happen, right? We're talking pulmonary embolism, acute MI, or stroke, right? So patients present with conditions that predispose them or put them at a higher risk for developing those type of conditions, then those are the patients who are probably going to be given anticoagulants. Now, they don't actually change the cardiac function. They don't really have an effect on cardiac function itself. What they do is simply reduce the risk for clotting, which reduces the risk for a thrombus to find its way into a coronary artery and cause an acute myocardial infarction. That's when it comes to the heart. That's what anticoagulants' purpose are. So I hope that helps. But I wanted to take this just one step deeper. When you're talking about drugs that affect the heart, okay? So you're talking about obviously working to prevent an MI. Then yeah, you're talking about anticoagulants, although they don't actually affect the cardiac function. Now, what do I mean when I say they don't affect the cardiac function? I'm talking about they don't improve blood pressure. They don't decrease blood pressure. They don't increase ejection fraction, things like that, right? They don't change the contractility of the ventricles. When you talk about things like that, you're going to get into some specific drugs. So what I want to do is just give you a real quick, a couple of drugs that you should be thinking about when you have different scenarios, right? So let's talk about drugs here that would affect afterload. Now you got to understand, afterload is the resistance of the ventricles, the resistance that the ventricles pump against. Okay, so we're talking basically systemic vascular resistance. If you make the systemic vessels smaller or you vasoconstrict them, you will cause SVR, systemic vascular resistance, to go up. Afterload goes up, blood pressure goes up. Okay, you make the vessel smaller. I heard somebody in a comment here said basically if you have a large tank and you make the tank smaller by making the vessel smaller, then pressure goes up, and that's true. The same effect will happen if you make the tank larger. So if you vasodilate, you will cause blood pressure to go down. Okay, so we're talking about drugs that are vasoconstrictors. We're talking about drugs such as norepinephrine, epinephrine, vasopressin, just to name a few. And then drugs that can cause vasodilation, we're talking about things like nitroglycerine, lisinopril, quinapril, our ACE inhibitors, things like that. Okay, now those are drugs that are going to affect systemic vascular resistance. They're going to increase afterload if you're talking to vasoconstrictors. They're going to decrease afterload if you're talking to vasodilators, and your blood pressure will change with the administration of these drugs. Now, the other thing we can do to change cardiac function or cardiac performance is by changing the strength of the contractility, which is essentially the force of each ventricular contraction. We can give drugs that increase this contraction. We can give drugs that decrease this contraction strength. Okay, so we're talking about our inotropic agents here, and you can give positive inotropic agents. These drugs will increase the strength of the ventricular contraction. We're talking about things such as dobutamine, digoxin, norepinephrine even has a positive inotropic effect on the ventricles. These drugs are going to make the ventricles squeeze stronger, so your blood pressure will go up. Negative inotropic agents, we're talking about our beta blockers like metoprolol or esmolol, even our calcium channel blockers such as cardine or cardizem. These are drugs that are going to decrease the strength of the ventricular contraction and cause blood pressure to go down. Okay, so when you talk about drugs that affect cardiac function, you're really talking about these four classifications of drugs. Of course, you can talk about antiarrhythmic drugs such as amiodarone or lidocaine. You can talk about drugs that treat bradycardia such as atropine, epinephrine, those type of things. Pulmonary vasodilators affect cardiac function by causing pulmonary vasodilation, which will increase blood flow back to the left side of the heart. The most basic one of these that is most commonly forgotten is oxygen. It has a mild pulmonary vasodilation property, but the big ones are nitric oxide, and then Flolan is one that we've seen kind of become more popular over recent years. So those drugs will improve or cause pulmonary vasodilation. Now, this is not the same as bronchodilation. Albuterol, in cases where bronchoconstriction is present, will lead to bronchodilation. That's talking about the airways. When we say pulmonary vasodilation, we're talking about dilation of the pulmonary vessels. This will reduce the effects and the workload of the right side of the heart. This will decrease pulmonary artery pressure, CVP, and improve blood flow back to the left side of the heart and improve overall cardiac function and cardiac output. So Teresa Grady, I hope I answered your question. If I didn't, please leave me another comment. I'd love to answer it for you. Just another real quick broad overview of some other cardiac drugs that you might be seeing. If you're talking about anticoagulants, you might be seeing some of these other drugs come into discussion. And it's a good idea to know what their function is and why we would use them to alter or to improve an effective cardiac state. Okay, hey guys, appreciate everybody watching. Hope everybody's having a great week back to school. We're almost to Christmas, guys. Keep going, finish strong. Have a good day.